About 6 billion people all over the world do not get adequate health care because the right knowledge does not exist at the right place at the right time. Project ECHO was developed to democratize knowledge so that underserved people all over the world can get best practice care. We say we would like to move knowledge instead of moving patients. In 2003, there was an 8-month wait to see me in my hepatitis C clinic. I would see patients with liver cancers, liver failure, cirrhosis. They were dying of a liver disease that we knew how to treat if only we had seen them earlier. New Mexico is a rural state, but patients sometimes didn't have the right car. Sometimes they didn't have the money to travel these long distances. It was at this time that I got this idea for the ECHO project. To use technology, one-to-many video conferencing, to leverage the expertise of a multidisciplinary team and bring this expertise to remote areas. We established a hub and spoke model where we had the university as the hub and we had these spoke clinics which were in rural areas. These were connected to each other so that patients could get the care where they lived. As we did this week after week, what we found was that these primary care clinicians became experts. Force multiplication had occurred. We had exponentially improved the capacity to deliver best practice care. And now we wanted to help many, many more people all over the world. India was almost a perfect replication site for ECHO. First, in the cities in India, there are experts who have the knowledge that is required to treat all the patients. Second, there was an adequate internet infrastructure. Third, the government had a very important priority to bring better health care to rural areas. Millions of people were dying every year of diseases we knew how to treat and cure.
ECHO India operates many programs throughout the country, focusing on critical issues like hepatitis C, tuberculosis, mental health, HIV, maternal and child health, and cancer.
Cancer in India is a growing problem. We have more than 1 million cases in a year, out of which about 50% die every year. One of the reasons why many of our patients come late is, especially in the rural areas, there is a dearth of knowledge as well as medical training for diagnosis and treatment of cancer. So we need to train people in cancer diagnosis, in cancer awareness, and also to be able to share their learnings with each other.
A very good afternoon to you all. Cervical cancer screening is very important in our country. Almost 8 women are dying every hour. So I'll be talking about visual inspection with acetic acid.
A typical echo session lasts for 1 hour and it consists of didactics followed by question and answer session, and that is followed by 2 case discussions which is presented by our spokes.
The first case will be presented by Dr. Ganita.
I'm going to present a case of a 40-year-old with history of irregular intermenstrual bleeding. A visual inspection with acetic acid was positive. A dense acetobite lesion was noticed.
So it's not only a question of the expert talking to the mentees or to the spokes, but it's also spokes learning from each other.
The ECHO model breaks down the barriers to moving life-saving knowledge. Using virtual rounds, primary care providers present on-patient cases, share best practices, and receive guidance and mentorship from specialist teams. ECHO creates a whole new community of practice in which all teach and all learn.
In our training, we have learned about cancer superficially, but ECHO has actually helped us to learn a lot about preventive aspects. And this is how we learned screening for breast cancer, cervical cancer, as well as for the oral cancer. We were able to come in contact with many more doctors. We were able to gain their knowledge, and now it is easier for us to impart the same knowledge to our co-workers, to our students, to our patients. Everything they have taught us.
We started off as a hub for cancer control in India. And in the last 2 or 3 years, we've trained more than 400 medical officers as well as paramedical workers in the rural parts of the country. And these individuals, in turn, have become master trainers and they are training more people.
Our work in India has the potential to be catalytic, in which the government of India can adopt this model and result in massive system change.
PGI Chandigarh was treating 1200 to 1500 patients a year of hepatitis C. 600,000 to be treated. There's no way this battle can be won. So ECHO came in and established spokes in the 22 district hospitals and 3 government medical colleges. And in 18 months, district hospital doctors treated more than 50,000 new patients. The cure rate is 93%. That's the difference that ECHO has really made.
ECHO has huge implications for the developing world. Africa has 56 countries. 14 of those are currently using ECHO. And they're even going beyond that because they're now actually doing some system strengthening work by helping laboratory workers develop a community of practice amongst themselves. They're also working with the African CDC to look at global health security. So they've gone beyond just the provider level, but now looked at how they can make the whole infrastructure around healthcare that much stronger.
My hope is, and my dream is, that ECHO projects will get integrated into healthcare systems so that it just becomes a way of doing business.
I think I have to hand it to them. A very interactive session.
Thank you so much. We'll see you sharp at 3 p.m. next Thursday. We're very, very proud to have spokes like you.
And if the model is adopted globally, it has the potential to change the world.